So just to give everyone a quick roundup of the team that we have here with us today. My name's Natasha, and I've been on the audit for about 1.5 years now, working as a project officer. We also have with us Naomi, who you've just seen. He's also a project officer to the audit. And for the team today, we've got Professor David Baldwin, who is our NCAAD clinical advisor, as well as Dr. Lorna Farquharson, who is our clinical advisor for the spotlight portion of the audit. So they'll be joining us as speakers for today. And we also have assisting us Maureen McGeorge, who is our QI expert for today. And she'll be facilitating a majority of the session, as well as a cameo video appearance from John Lodge. And he's from NHS England and NHS Improvement. So he'll be giving us a cameo video appearance. Apologies that he's not able to make it today, but hopefully you find the video really helpful. And finally, we also have Cara Oates from Greater Manchester Mental Health Trust. And she'll be here to give us a talk about her quality improvement project that she did in her inpatient service. So really looking forward to hearing that as well. And all of our speakers will be available at the end of the webinar as part of the Q&A, apart from John, of course. So if you have any questions, please do use the Q&A function at the bottom of your screens, which we will get onto in just a moment. So I'll just hand back to Naomi for the functions of the webinar.
Yes, so we really want today to be as interactive as possible. So if you can, just get involved where you can, that would be really good. So at the bottom of your screen, you should see 3 different icons. And the first one is the chat function, which if you press the little speech bubble, you can talk to your fellow attendees and you can also talk to the panelists. So if you click on the little arrow, you can change who this is going to. So we'll just see, can people type in where they're joining us from today? And we can see who we've got with us, just to practice. The Cotswolds in London, Avon and Wiltshire, Winchester. That's great. Grimsby, great. Oh wow, Brighton, Southwest Surrey, okay. And Norwich. Wow, it's a real mix. Okay. Alan from Tottenham. Oh, okay. Hello everyone, that's really nice. Okay, and then and Pen and Care. We've got the Q&A function and the raise hand symbol. So both of these we'll be using more towards the end of the webinar when we're going to talk to the panelists directly. So if you have a question throughout, you can type it in the Q&A and we'll come to that at the end. If you'd prefer to speak your question over the microphone, then this is when you would press the raise hand symbol, and then we have the power to unmute your mic from our end. So yeah, that's mainly for the end, but please just keep typing in the chat as well as we go through if you've got anything to say at all.
Yeah, and also just to mention for the chat function, I see lots of people, I think it's going just to panelists, so you can amend who your message is going to. So later on we'll be chatting sort of as a webinar, everyone involved. So if you can amend that to all panelists and attendees, then everyone in the webinar can see your messages. Okay, so onto the agenda for today. We'll begin with Cara Oates from Greater Manchester Mental Health Trust, and she'll be presenting a QI project on implementing a psychologically informed environment for inpatient services. And then we'll have our pre-recorded section from John Lodge, who'll be speaking a bit about how to get board members involved in your QI work. And then after this, we'll have Maureen, who'll be talking us through QI and change management and how to best get change to occur in your services. And then the last section will involve our NCAAD clinical advisors. They'll be going through the NCAAD recommendations, the importance of those, and then we'll go on to how we can use one of them to build a QI project from the ground up. So just before we get onto the first one, Naomi will take you through a brief recap of the last webinar.
Yes, so if you didn't see the last webinar, you can still access this on our website, and there's a link here on the slide too. So we just covered the core audit and the psychological therapies audit and the results of those. And then we had Maureen give an overview of the IHI model for improvement. And we had 2 QI case studies, one from Maureen again, and one by Dr. Sen Kalumpuram from East London Foundation Trust. So yeah, please go and see that again if you missed that. And so now we're going to go to a recording from our first speaker, Cara Oates from Greater Manchester Mental Health Trust. And she's going to be speaking about a QI project she started in her inpatient service.
Hi everyone, my name's Cara and I'm here to discuss Managing Difficult Emotions Pathway with you today. So just a bit about our area of practice. Keats Ward is a 22-bedded female acute ward in Salford, Greater Manchester, and it's part of Greater Manchester Mental Health NHS Foundation Trust. So here is just the aim of the Managing Difficult Emotions Pathway, and that is to provide support, structure to people who find it difficult to manage their emotions. So why was the pathway implemented? So it is quite a long slide, so I will just briefly discuss it. So as it says at the top, many of the patients we care for share a common experience of emotional trauma, and then that is managed using maladaptive coping strategies such as self-harm, aggression and substance misuse. What we was finding was that that people was obviously seeking increased one-to-one time with people, and this was quite problem focused as opposed to solution focused, which was therefore you know, things that we couldn't necessarily resolve there and then, such as concerns around housing and family dynamics, and this was resulting in a risk, an increase in risk to themselves and to other people. And also a little bit of disillusionment with in terms of mental health service as well from the patients too within the ward. Also, it was affecting staff resilience and their well-being as well, as it was resulting in them feeling quite incompetent, feeling that they wasn't doing enough to support the patient, and obviously then impacting on retention of those staff. So therefore, we looked at what we could do to support this. So therefore, we knew that we wanted some sort of structured pathway. So I sat down and met with our unit clinical psychologist and explained what we was doing at that moment in time on the ward. Luckily, what we found was we was already, a lot of the things that we were doing interventions on the ward were actually already underpinned by PSI interventions. However, we wanted to make sure that we had a bit more structure and an actual definite psychological intervention that was going to underpin what we was doing. Therefore, we decided on compassion-focused therapy, and we then began discussing the pathway and how it would look and kind of what it would involve with all members of the team, within staff meeting, line management, just in the nursing office. I think people got to the point, I'm probably still now where they're sick of me talking about it, but we just keep talking about it, looking at what training needs would be needed, supervision requirements, and then we started to plan how we would meet these. We also began discussing this with patients in community meetings, in one-to-one sessions, and also holding focus groups on the ward to discuss the intervention that we started to develop, making sure that they was happy with the way they looked, with the way the way they was worded, and they completely put their input into these. We then finally held an away day in April 2019. Where we discussed the full MDE pathway with all members of the nursing team and the MDT, so psychiatrists there, occupational therapy, our sports and recovery worker, our junior doctors, everybody was there, and we discussed how it would look, how we was going to implement it, and then we implemented it and it went live on the 8th of April 2019. So just a very brief explanation of compassion-focused therapy. So it focuses on 6 skills for development. That includes sensitivity of own needs, care for well-being, non-judgment, empathy and distress tolerance. And these skills developed hope to counteract any feelings of shame, worthlessness, fear and self-criticism, which often lead to maladaptive coping strategies. We looked at criteria for the MDE pathway. So this is including, but obviously not inclusive of the following there. And then we looked at how it will be prescribed. So it is prescribed through discussion with your primary nurse. So all our patients meet the primary nurse within 72 hours of admission. So it is discussed there. And we like to, where appropriate and with consent, discuss with the family and friends and carers and see whether or not they feel like the pathway would be beneficial for the person. It can also be prescribed through ward round, which is absolutely brilliant to kind of have complete buy-in from our consultant and the junior doctors in terms of prescribing this as well through ward round. It's fully explained the pathway to the individual on commencing the pathway. Leaflets are provided to the service user, and again, where appropriate, the family and friends or carers, and it's fully incorporated into their care plan. So how does it look in practice? So each patient is allocated to a team, and each team is made up of qualified nurses, nursing assistants, student nurses, and now obviously our aspirant nurses. There's a mix of skill and experience across all teams in terms of making sure that obviously we're providing the skill mix required to each patient. We're then allocated, the patients are provided with structured allocated sessions per week. So initially the pathway was introduced on Keatsy female acute, but it's now on to the PICU and going to be developed onto male acutes as well, which I'll go on to a little bit later. But just to say how it looks at the moment, so on the acute wards, they have 2 structured one-to-one sessions a week, and they're expected to attend 1 group session a week. And the PICU, they have 3 structured one-to-one sessions a week as well. As you can see just on the PowerPoint as well, that's allocated in a folder, and the nurse in charge checks that daily in terms of making sure that's allocated a time for that as well. And the patients get a little appointment card at the beginning of the week with the date of their appointment or group and who's going to be running that as well. Just to say, there's a shared responsibility as well for the patients to attend the groups, and they're not rescheduled for another time. You know, it's their responsibility to make sure that they're not doing something else and that they attend, but it's also the staff's responsibility to make sure that the patients are aware of their appointment, aware of the time, and groups are facilitated and one-to-ones are facilitated as well. Any support outside the session, you know, patients are referred back to the safety plans, which looks at obviously what the triggers are, really warning signs, and what they can do and other people can do to support them. You know, when they do approach people, they're completely validated and then you know, supported to work through the safety plan in terms of finding something that they can do to support them at that time. So on the first one-to-one session that they do have with the staff member, they do complete a safety plan, because the safety plan is what we keep referring back to throughout. So here is a list of the structured one-to-one sessions. I won't go into these in too much depth, but here's just obviously what they're called. Just to say as well that all patients, whenever they do have a difficult event, are asked to complete a debrief following difficult event as well, which they complete and then they reflect back on in the next one-to-one session. So whether or not that's an incident of self-harm or aggression, a difficult conversation, difficult ward round, anything like that, they're asked to complete a debrief, and then they discuss it in the next one-to-one, and they look at what they did as well, or what they could have done, and whether or not the safety plan needs updating. Here are the group sessions. So there's 2 skills group sessions a week and 1 social prescribing. So like I said, they are expected to attend 1 of the skills groups a week. However, we do want them to attend all the sessions if possible, and they are protected on the ward, protected time. All staff are expected to attend. They're facilitated by a qualified nurse, and there's a co-facilitator there as well, which can obviously support people should they be struggling in that session as well. So just briefly about staff support, obviously this is what training we identified throughout doing the pathway was what was needed. So and also what supervision and support that they require as well. So we have regular supervision, clinical supervision, balanced groups and reflective practice as well. Just a bit here about how we've evaluated the data. We looked at quantitative data for under those 4 areas, and also we've got qualitative feedback from service use through questionnaire, and from staff as well through questionnaires, and also through written feedback. So just to discuss very, very briefly, here's our self-harm, which we found a 61% reduction 5 months post-implementation. At balance and regression, we've seen a 10% increase in. There was also an increase in rapid trank. However, seclusion has been reduced by 83%, and the use of restraint has reduced by 32% as well. More importantly, the feedback from staff and service users has been amazing, and you can really see the impact that's had on the ward and actually the service we're providing, especially for people that have come back through ward admissions, from previous admissions or to different hospitals as well. Like, they report real benefit and of just the community really that we've managed to develop, and also the interventions and skills we're providing people. Just in terms of support from senior management, we've had complete support from our senior management in terms of, obviously it's been such a positive impact on the staff and on the patient care and experience that we've managed to now roll it out across, we're starting to roll it out across our unit. So like I said before, the PICU have now implemented this on the ward, and we're due to provide training once we're past COVID to the male acute wards as well, so they will be completing that. In terms of it being recognised across the trust as well, it has been recognised across the trust as a really innovative piece of work, and we've been asked and gone out to different forums and different areas of the trust as well to explain exactly what we do and what it is, and it's getting real interest as well in terms of people wanting to implement it across areas of the trust. Just a bit about overcoming barriers here. So obviously some of the patients were a little bit resistant to change at first, that I've been in before, feeling like because now we're saying you're only having so many sessions a week that they weren't going to get enough time or enough support. But then kind of once they started to be on the pathway and see the positives of it, now they feel like actually they get more time with staff. And then obviously the staff training, feeling like they weren't competent, which is obviously why we looked at what training needs was needed. And now we have a full training package before it's implemented onto the wards. Sorry, it's really fast. I speak really, really fast, but thank you very much for listening. If you have any questions, please let me know. Hi.
Right, thank you, Cara. So if you would like to ask Cara a question, just put it in the Q&A box and we'll get to the panelist Q&A at the end of the webinar. So you've got the whole webinar to think of things. And yes, so now we're going to move on to John's video. So we don't have John here with us, but he's given us a recording of some really useful tips and advice on how to involve board members in QI work. So here we are.
Hi everybody, my name is John Lodge. I'm the Head of Quality Improvement at NHS England, and I've been asked to talk briefly about a very, very common topic in the NHS, because it's a very common problem, which is around how we engage the buy-in of our senior leaders and our executive teams to engage in quality improvement. So it's a really common problem without a simple answer. But what's becoming increasingly apparent in all the evidence of successful organisational case studies for improvement is that executive buy-in is almost imperative. And because of that, there's an increasingly solid argument to say that we should, in the early stages, spend a very significant amount of our time and a sustained effort getting the buy-in of our executive teams and our senior leaders. I think one thing we need to recognise is that senior leaders, as you'd expect, have quite a big remit. And this remit will inevitably be bigger than the remit you're currently working on. And so we need to understand how our improvement efforts and our quality improvement approaches are relevant in their day job and relevant to their wider view of the world. And almost all senior leaders and execs will have some sort of accountability and some sort of interest in their role for the performance of their organisation. In other words, assurance will be a key lever. Now, historically, assurance and improvement have not been easy partners. They've either been one or the other. And I just really urge that we look through a lens of improvement and assurance being both really necessary, both really fundamental, but also perfectly complementary and not enemies. And with that in mind, when I'm trying to engage senior execs, I often start not by giving them a seminar on improvement methodology, or even by showcasing them interesting quality improvement case studies, but rather by showing them how understanding data and information through an improvement lens complementary to an assurance lens can help them in their day job right now, tomorrow, this week, for how they perform in their roles. And I usually signpost execs to the really popular Making Data Count series run by Sam Riley. If you look on Twitter for @SamRiley or just Google NHS Making Data Count, you'll find a ton of resource and access to professionals up and down the country who can come in and and run seminars, do work with your senior leaders and your executive teams. And a really, really powerful way of doing this is to take performance assurance data that's current with these people's portfolios and start showing them through an improvement lens, usually using statistical process control, how we can understand data in a time series through the lens of variation and understanding special cause and common cause. Through a lens of saying, well, this is about applying time, precious time and resources appropriately in the most effective manner and not making knee-jerk reactions. When I start with senior teams around effective use of data and analysis, I often find that it's a segue into more theoretical conversations about improvement methodology that ultimately get you to frontline quality improvement programs and conversations. But I think you need to almost create that sense of almost panic, right? That improvement needs to be looked at quickly and it needs to be taken as seriously as assurance. So looking at time series data through performance, making data count series can be a really, really effective starting point before we move on. Talking to other quality improvement leaders recently as well, I've also increasingly getting feedback that we need to make senior leaders and execs hungry for improvement. And talking about it, reading papers, CQC are a good example. They've got some fantastic publications on quality improvement, can be useful, but are not the most effective way. The most effective way by far is to go and see. We need to take these senior leaders and execs and take them to stellar organizations that are doing organizational improvement well. Show them what it looks like. Show them how it's visibly led by their peers at that level in that organization, what it looks like in practice, and how it translates into results. So take them to good organizations, take them to outstanding organizations, and show them work in practice. My most recent example was a visit to Western Sussex hospitals, and the chief operating officer there and the chief exec do a personal tour of their big room. They'll show you their boardroom and the structure of their board meetings and exactly how their business as usual is conducted through an improvement lens. In that particular case, it's a lean methodology, but there are all sorts out there. I'd also really recommend having a look at Sheffield Teaching Hospitals, for example, and their flow coaching academy. They run away days. Like, take your senior leaders and your execs on an away day and go and see with their own eyes and create that sense of envy and also that sense of understanding that it's possible. It is actually possible, and they can go back to their organizations and start to work with improvement advisors to build their own improvement infrastructure. And I'd also recommend networking your senior leaders and execs. So there are plenty of people who are doing the same jobs as them up and down the country, medical director to medical director, chief operating officer to chief operating officer. Put these people in touch with each other from outstanding organizations so that they can ask private questions about their nervousness of going whole hog with an improvement methodology. You'll find that they'll be able to talk to their peers and ask the daft questions that they might not want to engage with yourself if you're finding yourself in lower down the chain. So connect people with their peers. Take them to organizations on away days or avenues of opportunity. Sure, do the usual stuff. Show them literature and case studies of successful examples, but nothing quite beats a go and see. And I'm increasingly getting lots of feedback at the moment saying that it's well worth just spending lots of time getting that cracked. Because when you get a couple of execs and senior leaders that really start to believe it and see it, they start to show their colleagues and bring more and more until you get a sort of a majority at that level. Because when you have the majority at that level, they can then start to translate that into the strategy of your organization. You can then start to reliably get quality improvement written into your organizational development strategy, for example, so that your workforce can start to align and train and develop around your improvement approach. And everything I've just described is quite different to some of the simple, straightforward approaches that we've historically taken. So historically, you'll see teams up and down the country will create an improvement team and start doing projects and engaging staff, or they might start training staff in quality improvement to some scale. These things are fine, but they're not a sustainable, reliable way of getting quality improvement into your organizational way of working, backed by your senior leaders and execs in a reliably sustainable way. It can be a bit hit and miss. All that stuff comes, but I'd argue that it comes later once you've aligned your senior teams. So I hope that helps. That's just a few thoughts and reflections on a few years of supporting exec teams and boards with their organizational approaches. And just remember, this is a slow process. It can take a while, but we're increasingly understanding that it's not worth jumping the gun and trying to do random projects in organizations until senior teams are on the same page and starting to work it into their strategy. Anyway, good luck with it all. Thank you very much for your time, and I'm sure I'll bump into many of you soon. Thank you.
Great. So thank you very much, John. These are some of the resources that he's been referring to during his talk. So we've got the Plot the Dots, Sheffield Teaching Hospital, and some case studies from CQC. So hopefully that gave you a really helpful insight into how to involve board members in your QI work. And now we'll go over to Maureen, who will be giving us a talk on QI and change management. Hi, Maureen.
Hi, so I'm going to be talking to you today about some of the theory behind a lot of what John's just been talking around, and hopefully giving you some tools and techniques to take away and use yourselves. So if we can move on to the next slide, please. So just a few quotes about change. I mean, change can kind of be seen as a kind of a positive thing or a negative thing. So you've got the perspective of John Kenneth Galbraith, who said, faced with the choice between changing one's mind and improving, there's no need to do so. Almost everyone gets busy on the proof. And this is pointing to the whole thing about with organizations, when change is about to be imposed on people, people feel as though they're being told as though what they were doing wasn't good enough, and they can resist it. And you'll often find that things actually improve prior to a change because people are so desperate to prove that the existing way works. Then you've got Peter Drucker's kind of warning, really, in greatest danger in times of turbulence isn't the turbulence, it's acting with yesterday's logic. So it is that kind of thing about change is a necessary evil and we need to embrace it. And then I think finally Peter Sengi's kind of quote, people don't resist change, they resist being changed. And I think that's part and parcel of the problem that we often have with improvement work, is we try to tell people what to do, whereas the model for improvement is very much about empowering people to improve the services in ways that they think are going to be most effective and testing that out. So we just move on then to some tools and techniques. The next slide, please. So a nice quote here from William Bridges. He did a lot of work around transitions, linking into bereavement ideas. And most organizations try to start with the beginning rather than finishing with it. So it's this whole thing about not paying attention to endings and not acknowledging that people need to move through change. They can't just be told to change. It doesn't work that way. So as the next slide shows, you have to, if we move on to the next one, please. So you've got three different zones there. So you've got the kind of period where you know that things are ending, they're gone, you have to let go. You move through a kind of a neutral zone of adapting and getting used to the new idea of the loss, and then move into the new beginnings and embrace those, hopefully. And at the bottom, you've got the kind of the sort of the change junkies, the ones who kind of really let go really quickly, don't hang around in the neutral zone, and they just chomp up ideas and want to get on with the new ways of doing things. Then you've got the line along the middle there, which is the kind of time being spent a bit in the ending period, a bit in the neutral, and then into the new idea. Then at the top there, you've got the abnormal grief reactions. So people who actually never really let go of the past and can't really accept it. And so within an organisation, there's going to be people at all sorts of different points. And it's a responsibility of organisations to make sure that they acknowledge and work with that, and don't try and expect people to move at the same pace, because they simply can't. If we move on to the next slide then, please. So this is a lovely slide. It's based on Roger's adoptive categorisation work, and was then subsequently when Rogers did the work originally, he came up with the terms innovators, early adopters, early majority, late majority, and laggards. I'm sure many of you are familiar with that. And it's all about the sort of the speed at which people will adopt change, and John mentioned this in his presentation. Sarah kind of labelled it, so she used the terms enthusiast, visionary, pragmatist, conservative, and skeptic. I think much more helpful. So what you have here is that the first two groups, the enthusiasts and the visionaries, they're the kind of the sort of the real change junkies. So they're the ones that don't really need to be convinced. They look forward, so they're already heading in that direction. Then you've got the canyon that Sarah Fraser refers to, the gap between the visionaries and the pragmatists. And what they say though is that all of the groups kind of follow the group to their left-hand side. So if you can convince the early majority that the idea is a good idea, then the late majority will follow behind them, and the laggards or the skeptics will follow behind the conservatives. So really your important group to influence are the pragmatists. And the reason why I like Sarah's term is because actually these are the people who sort of stay within organisations for a long time, recognise that sometimes change ideas can be transient, and we daren't rock the boat. So they're the ones that need to be convinced. And as John said, and Sarah Fraser would agree, one of the most powerful ways of influencing this group is by taking them and showing them. So these are the ones that you take off to demonstration sites to actually see what good looks like, and then they can start to change their ideas, move across the canyon and bring the others behind them. So moving on to the next slide then, this is a lovely change equation, and it links again to what John was talking about. So what it says is that when dissatisfaction with the present situation multiplied by a vision of what's possible in the future, multiplied by first steps towards the vision, is greater than resistance, then you're going to get change happening. Now we all know that anything multiplied by 0 comes to 0. So if you haven't got dissatisfaction in the first place, you're not going to get change. And weirdly and wonderfully, if that's the situation and people don't actually realise that something that they're doing could be better, then again, that's why taking them and showing them is a good way of changing that. So effectively what you're doing is creating cognitive dissonance within those individuals, so they start to have dissatisfaction and they start to be, as John said, kind of hungry for change. So V, if they don't have V, so a vision of what's possible, again, taking them and showing them what's possible and actually showing them the results is going to be powerful. If they don't have F, you need to tell them what the first steps are going to be. So it's about helping make that real for them. So it's just a kind of quite a nice way of thinking as when you're kind of looking at resistance that you might be experiencing. Why is it that people perhaps are resisting the change, and therefore how, in what ways would you need to influence them? So moving on to the next slide. Force field analysis, I'm sure that people are familiar with this diagram, and what it's saying is that the blue bar in the middle there is staying exactly where it is because there are equal and opposite forces acting upon it. There's forces that are driving it forward are equal to the forces that are restraining it. So in order to move that in the direction of the change, then what you need to do is either reduce the driving or increase the driving forces, or reduce the restraining forces. And I think for most of us, we would like to think that we work to reduce the restraining forces, but actually when push comes to shove, quite literally, often our knee-jerk reaction is to try to kind of push harder. Well, again, it links back to the first two categories in Sarah Fraser's diagram. If the people are driving forward, they're driving forward anyway, so actually your efforts are a bit wasted focusing on those groups. It is far more constructive to actually work to try and restrain reduce restraining forces. That will help move the blue bar. And then the final slide links into the same point. So this is a kind of just a little tool that can help you kind of work out where your resistance is coming from. So what you want to do is in the first column, list down the different people that need to be involved in helping you to move forward with it, with an improvement plan. And then subjectively, put with perhaps an X, which column do they currently sit under? So are they likely to oppose what it is that you're trying to do? Will they let it happen? Will they help it happen? Or are they going to make it happen? So mark where they are currently, and then mark again where you need them to be. So that immediately shows you where your efforts need to be focused. So in that example there, you can see that the chief exec of the organisation would currently let it happen, but in terms of leadership, and as John talked about visibility from the top, it'd be helpful if he could actually be moved into the help it happen box. Most of the other people, we can see not much change is needed, but then you look down at the people in opposition. You've got the 3 different doctors there who are all going to oppose it. Now, as we said, if they're going to oppose it and they're resisting it, then the chances are things won't go ahead. You don't need to move them into the Make It Happen group, but we do need to move them into the Let It Happen group. And this particular example, all it took was for one of the senior leaders to actually meet with those people, allow them to kind of express their concerns and their reservations about what was going on, and then they moved into the Let It Happen box. So it's a bit of a good example of Pareto as well, because it's allowing you to focus your efforts so you get the biggest bang for your buck. Next slide, please. Okay, so thank you very much. And at the end, there'll be, if you want to note down in your Q&A if there's any questions, and we can deal with them at the end. Thank you.
Great, thank you, Maureen. That's, yeah, really, really interesting. So now we're going to think about 2 of the NCAAD recommendations and hear from our clinical advisors about how the recommendations were picked, why they're important for the provision of care, and how trusts should view the recommendations in terms of improving the quality of service they provide. So, and after that, we're going to attempt to build a QI project plan collectively using one of these recommendations as a base. Okay, so over to David.
Thank you very much, Naomi, and hello everyone. I was thinking about the recommendations from the core audit whilst preparing for this webinar, and one of the things that struck me was the recommendation relating to the need to have systems for assessing the effects of treatment for people with anxiety and depression. So if I could have the next slide, please. This really comes based on my own experience as a junior doctor, when I used to periodically assess patients in the outpatient clinic and noticed that over the years they'd always been described as a little bit better at the time of each appointment. But actually, when you reviewed things with a longer term perspective, you realized that they were essentially unchanged after 2 years. And it struck me that just relying upon a patient's words or your own impression may not be the best way of assessing change. And this got me interested in the use of scales, either used by patients or by clinicians. If we think about anxiety and depression, most of our patients have symptoms which fluctuate in terms of their severity in a given week, or the number of days with that symptom, or the degree of distress that they feel at a particular time, or the impairment, the things that they can't do as a result of having those symptoms. And having some form of quantified measure, a scale, I thought is helpful in monitoring progress in the way that we use, for example, blood pressure to monitor the effects of treatment of patients with hypertension. So next slide. So what we found was that actually trusts varied really quite considerably in the use of outcome measures. So for example, there was one trust that actually it appears that they used such outcome measures in 100% of their service users, whereas by contrast, another trust, they were only being used in 7% of service users. Another finding was that outcome measures were being used on average in about 61% of individuals, but they tended to be only used once, so that you couldn't really get an assessment of change for that individual. And then a third finding was that actually there was no consensus on the use of which particular measures to use. So we made a recommendation that trusts should agree and implement reliable systems for assessing the effects of treatment. Now, of course, that actually requires quite a few changes. So clinicians need to be trained in the use of those outcome measures, and trusts need to show that these kind of training programs are in place, and also that actually there's a system for assessing change and collecting the data on change, and also analysing it so that you can compare your performance to neighbouring trusts. Thank you. So if we think about how we get there, well, what's the guidance? Well, there's an organisation called the International Consortium for Health Outcomes Measurement, which is a bit of a mouthful, but they look at common medical conditions, and they have turned their attention to anxiety and depression, and have recommended a scale which is based on the very well-known PHQ-9 and GAD-7, which most of us will be familiar with because they're used in things like IAPT services. Those two scales together include 16 items, and the organisation recommended 3 additional items relating to particular symptoms to be used periodically over the course of treatment. And then they also recommended another scale or questionnaire which had 45 items, again completed by the patient, which is used to assess more broad outcomes such as remission and return to work and resumption of other responsibilities. But as I said, to implement systems such as this requires quite a lot of training and engagement of health professionals, and also in particular the co-development of systems for this with our service users. And finally, the implementation of computerized systems to ensure that these scales are being used regularly, the data is gathered in a fairly easily analyzable way, and finally that those analyses are undertaken. Thank you very much. Thank you.
Great, thank you very much, David. I can see we also have a raised hand in response to that section from Fiona Roberts. So we will come to that right at the end of the Q&A, at the end of the webinar, where we can turn on your microphone and you'll be able to ask a question that you have for any of the panelists. We'll just go on to Lorna now, who'll be speaking about a recommendation from the core audit.
Thank you, and hello everyone. So I picked this recommendation because we know that good mental health care includes access to evidence-based psychological interventions, but we found in the audit that many people were not being referred for psychological therapy. In fact, over half, 61% in the whole sample were not referred for psychological therapy. And we also found a large variation in the referral rates across trusts. And the first part of this recommendation here is that clinicians should ensure that all those admitted to hospital are offered an assessment for psychological therapy in line with NICE guidance. And this is about increasing routine access to evidence-based psychological therapy and improving the therapeutic offer available in inpatient settings, which we know is beneficial for outcomes. And we heard a really nice example earlier from Cara outlining the steps that were taken to increase access to psychological interventions and the beneficial impacts that were noted there. And within this recommendation, if we look at the last part of it, there's an emphasis on the importance of recording the discussions around referrals. And it's important to ensure that the rationale for deciding to refer or not to refer is recorded, and also that we're ensuring that there's shared decision making here as well. At a trust level, it's important to be looking at the reasons for low referral rates and investigating what's behind those, and that's actually another specific recommendation that we made in the audit. And it's also important for trusts to be looking at the availability of psychological therapies in different service settings and being able to address any gaps in provision and increasing capacity where needed. So I'm keeping this quite brief, because I know we're going to move on now to looking at how we can develop this recommendation into a QI project. Thank you, and I'll hand over now.
Amazing. Thank you so much, Lorna and David, for that. So as Lorna's just mentioned, we're going to move to a more collaborative session now, where we'll be trying to build a QI project based on the recommendation that Lorna has just spoken about. So improving access to psychological therapy. We'll have a few polls at this point. So it will come up prompted on your screen and you'll be able to select your answer. And one of those will be multiple choice. So please do select as many as you feel are relevant. For the other parts of the session, we will also be prompting you to use the chat function if you have any thoughts or ideas that you'd like to voice as well. And I can see it's already being used lots, so that's great. So I'll hand over now to Maureen for this.
Yeah, thanks again. Right, move on to the next slide. So the problem of improving access to psychological therapies. What do we know is going on? I mean, thinking about your own experiences, what kind of things might be actually a more sort of in-depth explanation of what's going wrong. So I think we've got some options here on a poll. So what's leading to poor access in your services? If you want to use the boxes, you can apparently tick more than one option. So what kind of problems have you experienced around accessing psychological therapies? Is it about availability, waiting lists, eligibility criteria being unclear, so forth? Could take those and then we'll see the results when they come through. The important thing here is that until we actually really understand what's causing our problem, we can't really begin to think about strategies for fixing it. How are we doing?
Still a few more votes coming in, so I'll just give it another 10 seconds.
Cool. Oh, somebody's saying they haven't got the option to vote, unfortunately. Is there any way we can help with that?
Anyone that can't vote, do feel free to use the chat and mention which one you think is most appropriate to you.
I reckon I know what it's going to be. Oh, secondary community care services in general are very poorly resourced. Okay, there we go. Limited availability, and that maybe links into the callers that commented in the chat box about limited availability, particularly in secondary care. We've got quite a number of people talking about long waiting lists, which could mean that people give up waiting or find alternatives or whatever. Eligibility, yes, so all of them seem to be factors around poor access. There's a big difference, isn't there, between services not being available and people not being able to get to those services. So yeah, we really need to understand what the problem is. So let's move on then to the next part of this then. So what kind of diagnostic tools might you use to help you understand what was causing the problem? So here's some options then. So, and if you had any experiences yourself using any of these tools, or if you think that they might be helpful to help you kind of dig a bit deeper. If you want to mark which tools you might use. Okay, I'll read out the options somebody's asked. So the options are existing data, brainstorming, the 5 whys, staff survey, patient survey, or any other ideas that you might want to tell us about in the chat box. Are we still getting responses coming through?
More, yeah.
Cool. Looking at existing data, yeah. So, okay, so that's really interesting. We've kind of got quite a good split there as well. So some people looking at existing data. So I guess that's kind of things about where the referrals might be coming from, what sort of numbers that you're dealing with. Brainstorming, so speaking to the team that's involved. 5 whys might be something that you did with the team. Staff survey, great. That might well be either surveying the referrers or the service themselves. Patient surveys, if the attrition rates were high. And I'm liking the answers that are coming back because it's pointing to the whole thing about the broad array of different ways in which we can dig deeper into the problem. And sometimes we start off using one tool and then we start to realize that actually we need to dig a bit deeper using other tools. So great, okay. Should we move on to the next slide now? So here's just an example. So if, for example, when you realised there was a problem with accessing psychological therapies, you looked at your existing data, which was seen as a favoured option by a lot of people, that might show you, for example, that some teams were referring into the service and others weren't. And if that was the case, your next layer of digging might be to go meet with one of the teams that wasn't referring and actually understand what was going on, why they weren't making the referrals. And that might then tell you it's because they were unclear about who should be referred and how. So that's just kind of an example of how two teams might, how two different techniques might be used, one after the other, to better understand the problem, so that you then know what it is that you're going to try and do about it and what you're going to try and improve. So move on to the next slide, please. You might then come up with a statement of aims. You've worked out what's going wrong, and now you're going to work out what you're going to do about it. And the important thing with statement of aim is that you're going to be specific about where you're going to do the work, and what is that you're going to try and do. You're going to try and specify how much improvement you want. That's not always easy, because until you've actually dug into the problem, but you sometimes don't know how good is. And similarly with time, sometimes you don't know how long it's going to take, and it's better to kind of say 9 months rather than 2 months, because 9 months might be too long and you might achieve the results sooner than that. But if you say 2 months and it takes 3 or 4, people might feel as though they've failed. And then the third point about it, final point there, the final bullet, everyone agrees with it. So everybody agrees with it. So here's an example of a possible statement of aim. That aim might be to increase the number of referrals from Team A by 30% from baseline by December. So you've got a team-specific team you're going to be working with that currently aren't referring. You want to put that up to 30% of the referrals coming from Team A. And really important point at the bottom there, Team A really recognises it's the problem, because if they don't recognise it's a problem, well, back to the change equation again, there is no dissatisfaction, so they're not going to do anything about it. Okay, so if we move on to the next slide, please. In terms of measures, this is just a quick sort of reminder of what the measures might look like. So straightforwardly, in this example, the outcome measure relates back to the aim. So your outcome measure would be the proportion of referrals that come from Team A, either weekly or monthly, depending on the number of referrals coming through. Process measures, they'd relate to which parts of the system are broken and where you're going to focus your efforts. So if, for example, your intervention was going to be around getting staff to deliver information leaflets about psychological therapy services, then it might be the number of leaflets being given out per week or per month. And you would expect that as that figure increased, also the number of referrals going through would. Balancing measures are the kind of what people worry about, and in this instance it might well be that the services themselves, psychological therapy services, were saying, well, if we increase demand by that much, are we going to be able to meet that? We could increase our waiting times. So that could be a balancing measure that's worth measuring, because it may actually be accurate. Okay, move on to the next slide, please. Change ideas. So the change ideas are the kind of what needs to improve. And the example here, it might be we need better information about psychological therapy services. The how you're going to do that is the PDSA, the Plan, Do, Study, Act cycle. So we know what it is we want to do, but we don't exactly know how. So I'm just wondering if in this particular example, what kind of ways might you look to improve psychological therapy services information? So what kind of things might you be testing out? You can just use your chat function to do that. You will see things appearing in the chat. So what kind of ways might you test out provision of better information? Make a leaflet. Yeah, I mean, it's a great example, and it's obviously the kind of the go-to, and I think a lot of people do. But the important thing in relation to quality improvement approaches and Plan, Do, Study, Act cycles is you would sit down with the right people in the room. So you'd involve people who would be using the leaflet, the receivers of the leaflet, and also the staff, to make sure that the information itself was well written. And you might well do something, and then somebody said, well, actually, there's too much information there. There's too little information there. The font's too big, the font's too small, we need photographs. So that's the whole idea. So rather than a few people going into a room and coming up with a leaflet and getting 3,000 copies printed off, you'd actually be testing it on a small scale way so that the leaflet actually worked. But equally, it might well be that actually a leaflet isn't the best thing, that you need something that's available on an app on a phone or whatever, because there's also different ways of communicating information. That's really just kind of the PDSA side. Yeah, somebody's saying here, I'm always keen to steer conversations away from money, resources, discussions, systems change. Yeah, Oh, somebody said the microphone's on correctly. Sorry. Should we move on to the next slide, please? This is really just to kind of illustrate a run chart. So from this, this is a run chart of the proportion of referrals from Team A. So you can see the first 10 data points, because their baseline was 0, so you've got a baseline median of 0. So which PDSA was the one that brought about the step change? So you're answering your in the chat room. Yeah, so Kevin's saying 3, Emily's saying 3. 3 is indeed the correct answer. So you can see that that PDSA 1, there was a slight increase in referrals. So that may have 1 or 2 people were influenced by whatever was done then, but it dropped back down again, similarly with PDSA 2. But when you got to PDSA 3, there were significant improvements in referral levels such that the median had to be adjusted, and the median post PDSA was operating around the 14 level, so quite a significant improvement there in the goal towards the 30%. Okay, I think we can move on to the final slide now. Thank you.
That's great. Thank you, Maureen. Yeah, so it's now time for the Q&A. So please, if you've got any questions, I know that Fiona had her hand up and she's just said something in the chat that she has to leave.
I could answer that. It was about how to get whole services on board, and it struck me when I saw the question that perhaps one way to do this is to have the initiative led by service users, because obviously we all interface with service users in differing ways. So actually to have the the patient experience advisors that most trusts have bought into this might be a useful way of actually rolling out a kind of educational program.
I come in as well. I'm involved with the National Audit of Psychosis, and we did a webinar last week, and there was actually a brilliant recording around exactly this subject, around research that's been done on this, and I found it really powerful way of kind of encouraging outcome measurement when you actually hear what service users say about how valuable it is to actually have some impartial measure of their own progress. So that's well worth a look. I think you'll find that on their website.
Okay, brilliant. I think we're just going to go to the questions that we had pre-registrations or during registration while we wait for other people who's got to answer already. And the question is, do you have examples of QI projects that were particularly successful in terms of multidisciplinary buy-in? So back to Maureen for that.
I'll just talk this through very quickly. It was when I was working with the college, it was a team from the Southwest, and they came along with this project, and I thought, oh my goodness, that's hugely ambitious. It's a really big piece of work, because the problem was around access to a small number of inpatient beds for young people, children, young adolescents with mental health problems. So the aim was simply to reduce the demand on the inpatient beds, and the measures were going to be the bed days used per calendar month. The team that was involved, really broad, so it was the inpatient staff, it was staff from the 2 serving community teams, and also the outreach staff. And they currently already had a meeting that was taking place, weekly meetings with each of the CMHTs that would be attended by the inpatient staff and the outreach staff. So the change ideas, it was nice and neat, this project, because really there were only 2 ways that you could reduce demand. One was either by reducing the number of admissions, or the other would be by decreasing the length of stay. So in terms of the PDSAs, for reducing admissions, what they did was they introduced a new agenda item to the weekly meetings of identifying the 10 young people most at risk of an admission. And so they proactively planned for what would be the best thing for that young person. So rather than knee-jerking and having to go and use hospital as a last resource, they actually went ahead and planned what would be better for that young person. That was a massively effective way of managing bed usage. And in terms of decreasing length of stay, what they did was they focused a lot of energy on making sure that young people's needs were assessed very quickly after they came into hospital. In fact, as the project moved on, it moved to pre-admission, so it became purposeful admission into hospital. And if we should see from the next slide, what they got was a reduction in bed days from 250 down to 100, which eventually settled around about the 150 mark. But what they also reported was increased cooperation between the teams because they were working much more together, more timely management of the discharges, and actually smoother transitions for the young people in and out of hospital because they were working so well together. And a quote from the consultant psychiatrist who led the work saying, "It's been a focus on treating people as well as possible, joining around an aim that everyone could sign up to." So I thought that was a fantastic example of a fantastic piece of multidisciplinary work, as was Cara's example earlier on. I mean, that whole thing about working with a team is so vital. Any other questions come in?
Yes, I think we do. We've got one question here for Cara in the chat, but I'm not sure if her connection's there. Are you there, Cara?
It strikes me
She's
that
actually trying to move. She's lost connection.
Yeah, that's okay. We can pass it on.
Cara, yeah.
Yeah, we'll pass that on through email and get her to get back to you.
When we spoke about this yesterday, Cara said it had been maintained, and I'm sure she should have a visit.
Great, and we also have a couple of more questions that were sent in. Completely understand if any of you have to head off at this point as we've reached the hour, but it will be recorded, so feel free to refer back to the webinar recording and we'll answer the questions here from the panellists. So these are just a couple more sent in during registration. So the first one here is, do you have a repository of change ideas implemented by providers which have proven to improve quality in their areas? So I'll put that to any of our panellists if they'd like to answer.
I would refer people to the East London's website because what they have invested a huge amount of effort in their infrastructure for quality improvement, and they use LifeQI, the system for recording all of that. So on the website you can see posters for all of the different work that's going on there, which kind of summarise the work. And I know that on the previous webinar, it was one of their projects that was talked about. So to go to them, I would suggest.
Fantastic, thank you, Maureen. And just the last one here that was sent in before the webinar was, why did the audit not take into account staffing levels and number of patients which are critical to service delivery? I wonder if one of our clinical advisors would like to answer that one.
It's a really good question. Obviously, you can't necessarily compare a very rural environment with a very urban environment. And you know, we've found, for example, that the proportion of service users were homeless varied quite markedly from trust to trust. So you do need to think about the case mix and the staffing level. One of the problems, of course, is that we're looking over a period of 6 months, and there's actually always quite a lot of seasonal variation in the type of people who are admitted to hospital, and also quite marked variation in staffing level provision over the course of the year. So it would be hard to get reliable data there, but it's certainly a good question. And I think the idea of the audit is, you know, it produces findings and recommendations, and those then lend themselves to more formal research studies which can explore this kind of thing in more detail. Thank you.
Okay, I can't see we've got any more questions just yet. So I think we'll just take the opportunity to say thank you. Yeah, thank you to all our panelists. So that's Maureen, Lorna, David, John and Cara. Thank you for all your expert advice and for your guidance today. And I think we will stay on for another 5 minutes or so if anyone's got any more questions. But yeah, we really do hope you found it useful, and please send it on to other people, send it to your colleagues, and yeah, watch again and feedback anything that you do with your trust back to us or to other people.